See, my talk is on the commonest killer disease of humanity. Despite all the medical advances, this continues to be that. And the tragedy is it can happen suddenly, without a forewarning, and almost always the first cause of an MI, the first MI is always in the unsuspecting, so-called perfectly healthy person. There lies the problem. This disease is not unusual. This has been known 3,500 years back. In the Egyptians have documented. If someone complains of pain in the chest, arm and abdomen, tell him that is threatened by death. We all knew it 3,500 years back. So that from there to now, what we can do to save them is what the story of medical science and evolution has been. It's not just long back, only about some 170 years ago, we could identify that the problem of so-called pain suddenly dying off was happening from the coronary artery, where the plaque was rupturing, and this rupture can take as little as a moment. It is a moment actually, an instant, and then the blood will get clotted on the contents of the cholesterol plaque are exposed to the blood column, thrombosis, clotting time you all know, 6 to 12 minutes, and if you are intrinsic thrombolytic system is not good. If your intrinsic anticoagulant system is not good, an occlusive thrombus and a massive MI, which in 25% will cause primary ventricular fibrillation, sudden death, you can't even reach the medical care. So this is the problem. The shortest distance between perfect health and utter catastrophe is as short as a plaque rupture thrombosis distance, which could be a few minutes. That is the problem. These are the triggers. The disease, atherosclerosis, as you all know, will be there. It's ubiquitous. From 6 years of age, fatty streaks start. From second decade, you start getting some pathological intimal thickenings. But then the triggers, the commonest triggers are unaccustomed physical activity, emotional stress, any infections. There is a reason we say, if you find a diabetic or anyone who is prone for cardiac events, go for prophylactic annual influenza and pneumococcal vaccination, because at least the known infective problems can be taken care and one trigger is being taken care. STEMI is important because once the vessel occludes and he has not succumbed already, you can at least open up that artery, allow the blood flow and save the heart muscle as well as save the patient's life. This is a crucial part of why STEMI is important, and primary care practitioners are very important in this ball game because the patients will reach you first. You should know how to deal with them and then we'll take over from there. If you miss the diagnosis of an MI, this is what will happen. One VPC unsuspecting. This was a patient who goes for an ECG while it is being recorded. One VPC is enough to kill a patient. So be aware, you are the responsible people for seeing these patients on the battleground. You are seeing them day in and day out. In the current day, if you find a patient who comes with a chest pain and ECG showing ST elevation MI, what should you do? First see where you are working. You are working in a scenario where you can refer the patient to a center where they can do a primary angioplasty. Primary angioplasty, you open up the artery, the block, put a stent and get the blood flow going. If you can do that within 120 minutes, you can transfer to a place where it can be done fast. Then you refer off, transfer off. That is the best. This is the patient. 3.5 hours pain, but he can be shifted because he is in Chennai. One loading with aspirin, clopidogrel, and then statin and heparin, plain heparin, shifted to cath lab, informed that, yes, there is a STEMI patient coming. What shall I do? Shall I refer off primary? Yes. Primary care, the primary PCI centers are also called STEMI treating centers, where the cath labs are open all around, 24/7/366, whether COVID or floods or whatever it is. That is called a primary PCI center. Not just having the ability to do angioplasties, but the labs are closed in the night, open in the morning, no. So primary PCI centers in the country are very few in between, but I think all of us should gear up and develop more such centers. Ours is such one. Once the patient is diagnosed, you know that you can shift the patient quite soon, shift off to the thing, inform us, we will take him to the lab. Quite simple. Almost always we find an angio-MI will be like this. These vessels, unfortunately, the drama happens in the starting part of the arteries, and this is where the problems happen. For us, it's very simple. Just pass a wire, put a stent. The nature has already created the plaque rupture. Our job is to tack it and then put a stent, and then the patient's muscle is saved and the patient is saved. After 2 days of stay, we can discharge him off, and again the secondary prevention goes back, the patient goes back to you and you have to take care of the patient to prevent these events from happening. Another such story, this is a patient where you know that this patient cannot be shifted to a primary PCI center within 120 minutes treatment time. Then what do? You have to thrombolize, because time is important as well. So you know that this patient cannot be shifted, he's in a little bit far off place, so you thrombolize them. In thrombolysis, make sure you are not adding prasugrel. Even ticagrelor, some data is there, but preferably use clopidogrel and aspirin, and probably heparin or LMWH, thrombolize the patient. But thrombolysis is not the end of the treatment. The game starts now. The moment you thrombolize, see whether the patient's pain has settled down, ST changes have settled down. If it is not, that means you are in for a big trouble. This is called as failed thrombolysis, and the mortalities are quite high. Immediately ring up the primary care centers, primary PCI center, and tell them, we have a failed thrombolysis, we are shifting off. Better is to inform them at the time of starting thrombolysis itself. In countries like France, they thrombolize while in the ambulance when the patient is on the way to the cath lab. That is the ideal strategy. So here, this patient, things don't settle, he's sinking, shifted for an emergency angioplasty. It is a deadly scenario, but luckily here, some flow 1%, that is good enough for us. In the lab, as I said, the job is quite simple. Just put a stent. These procedures, most of the time, they just take about 10-15 minutes. The process of primary care practitioner to our cath lab, primary PCI cath lab, the doctors managing that, starts once the diagnosis of STEMI is made. Transfer. If you are thrombolizing successful, you can wait even for successful thrombolysis. This is an important message I want to convey. Better transfer off within the first day. The current guidelines tell you that even with a successful thrombolysis, an angiography should be done between 2 and 24 hours. It should be done within the 24 hours, as early as 2 hours, and if there is a residual block, you put a stent and save the patient. Because thrombolysis, in those where successful thrombolysis is done, many a time, 85% of time, the block will still be there. It has opened some flow. We do in the lab, we make it normal. This is a failed thrombolysis. Very important scenario. We can do a good job. Many a time, for successful thrombolysis will do like this. The lesion will still be there, we can complete it off. So this is called a pharmaco-invasive strategy. The patient cannot be transferred, give the thrombolysis and shift off anyway. Whether successful also, we'll complete it off and take the treatment from there. A bit of caution. We need primary PCI centers all over, but then one should be careful because these angioplasties are not like the usual planned, cool angioplasties. Patients, things can be sometimes very surprising and you will be landing up in a lot of challenges there. So better to have centers where some people can guide them into taking up the challenges as well if they arise. Sometimes these scenarios are very, very simple. One small LED here can give a scenario of a low risk, high reward primary PCI. Sometimes very low risk. You can do that. This patient comes all the way, driving 4 hours for this. Sometimes scenarios where nothing else will work. A cirrhosis, recent GI bleed, and then if you see complete heart block, always, almost always, the patients were sick. They're always the proximal vessels occluded. You can open up and then give them life. Sometimes they come so late. Sometimes fibrillation. While the massage is being done, you will be doing these patients. These are all important patients. On massage we can do. Nowadays we have supported PCI. We can have an IABP. We have Impella. Yesterday, as I was, we were doing an Impella guided PCI. We can do the cardiac output continuation with protected PCI and deliver the job. In dying patients, we can save many of them. Even if they are having VTs in the ambulance, shocks, and then we can save them any long distance. So the ability to save these patients has increased tremendously. Someone who has out of hospital cardiac arrest, this patient was given 17 ampoules of atropine, unconscious, sugars. You can see the scenario. Still, that small MI is causing all this trouble. We can save them. Out of hospital cardiac arrest, we can save and then do hypothermia protocol. Sometimes abnormal vessels will be there where they are not arising from the normal area. These are the challenges. The primary care, primary PCI angioplasters should have the enough technical expertise to tackle even the abnormal AKOS vessels. Multiple blocks, no problem. You can decide to do the primary one and do the remaining one probably within the next 2 to 6 weeks. Routine thrombectomy, we need to suck out all the clots and take out and then do the angioplasty. Nowadays, we don't do that, except in a rare scenarios like this patient, where a young patient, where we could just take it off, or delayed presentation where you can take out the clots and then put stents. Too young, you can see here just clots. Take out the clots, white clot, red clot, thrombectomy, very simple, and then you need not even put a stent. You can do a plain, simple thrombectomy case. Dying patients, compassionate, We don't know whether the brain is alive or not. We can still do that, do the job, send for a hypothermia protocol, 24 hours later see that many a time we are able to save them. Sometimes we get challenges full of boulders, then we need a rotablation to do the job. IVL is also available now. We will be discussing about these technologies in the last sessions. Out of hospital cardiac arrest we have covered. Sometimes abnormal things, a left main bifurcation like this, and then you have to do some innovative techniques. Here we are doing a simultaneous kissing stent and saving the patient. Sometimes extremely rare disorders like this young lady, 32 years, recent, 5 days old, pregnancy, delivered, scissor, and then you can see a left main scenario, complete, you can see the pseudoaneurysm-like appearance there, and entire trifurcation left main with a false lumen everywhere, spontaneous coronary artery dissection. Once upon a time, these are all diagnoses made in autopsy series, but now we can go into the lab and then save these patients. Primary PCI has really revolutionized, probably one of the greatest advances the human civilization has made. This patient, you can see after 6 months how the angio is perfect. A true STEMI lab will work even in the COVID or floods. In the COVID time, our primary PCI program was running in the same way. In fact, we were doing more primary PCIs because other hospitals were not taking up such cases. We were able to save a lot of patients with this scenario. Have we conquered death? That is a question I always ask myself. Still no, because some patients are dying. The main reason being the delay. The delay is happening mainly at the patient level. Rarely, sometimes, primary practitioners who are not aware that time is crucial, they make a delay, especially in the paradoxical scenario. They think the thrombolysis has worked. Why not stabilize him and shift after 3 or 4 days? They have a second infarction and then they die off. Shift off as soon as possible. Of course, in the lab, those who present late, they have no flow, slow flow. At the other side of the coin is bleeding. We should be pragmatic in having a balanced judgment of these scenarios. Surgery, very important scenario. There are certain cases of primary MI, acute MI, where only surgery can help. A papillary muscle rupture with a severe MR, a free wall rupture, or a VSR. You can't do the patient by just angioplasty and ignore the mechanical complication. These are rare cases, but you should be able to identify them so that you don't unnecessarily load them with antiplatelets and the surgeon's hands are tied. In conclusion, this is the killer disease which will continue to hold its sway on us. Primary care practitioner's role is crucial. We can go into preventive strategies as well. We can discuss in the next sessions. Do not miss the diagnosis of ACS. If you have a doubt, it could be acute coronary, acute aortic syndrome, it could be acute pulmonary parenchymal syndromes, acute pulmonary vascular syndrome, acute gastrohepatobiliary intestinal syndromes, whatever it is. Rule out ACS first and primary, because this is the one killer disease which might not give the patient a second chance, even a second minute more. The management of ST elevation MI revolves around cath lab. Wherever you are, decide whether you can shift straight away or do the primary therapies like thrombolysis and shift over. It revolves around that real cath lab. Advances of primary PCI are there. A good center should have all the facilities, including supportive strategies like Impella, as well as techniques like rotablator, IVL et al., so that we can save maximum number of patients and deliver our job. Thank you.